Okay, Dr. Fairfax, if you want to go ahead and start the introductions.
Okay, and is it Internet? Can you make me a co-host so that I can share my screen? Perfect, thank you. Okay, hi everyone, I'm Jaymes Fairfax-Columbo. I'm a forensic psychologist in the department. And first I want to start off by thanking CBH. This is a CBH-sponsored talk. Myself as a member of CBH, they're graciously allowing us to showcase some of the work that we're doing at UPC to sort of change the therapeutic orientation there a little bit and really focus on improving clinical care and by proxy reducing violence risk. So some of you may know that there's a assault reduction working group in the department. We meet once a month or maybe a little bit more often than that. And we're trying to figure out ways to increase safety throughout the hospital, right, in our inpatient units. So this is really more of an applied presentation. We really want to give people a sense of exactly what it is that we've been doing. It's occurring to me, is my PowerPoint being shown? I feel like it's not.
It is, we can see it.
It is, okay. So we're sort of doing this in group style, right? So I'm going to talk a little bit about the theory behind violence prevention and violence risk reduction, but we really want the focus to be on the need for this new orientation and really to give focus to some of the things that are already happening in the hospital and that will be happening very shortly. I really appreciate CBH for letting us present this because it's a recognition of sort of a continuum of care, right? Individuals, when they come into the hospital, they're coming from the community, and our goal is to return them to the community, right? We're not trying to hold anybody for a long period of time. So sort of in recognition of that, CBH really thought this was a great talk for us to give. So I'm gonna be co-presenting today. We're also gonna have Dr. William Wylie, who's one of our psychiatry residents presenting, Dr. Antoine Ho, who is a Ph.D. in molecular genetics and microbiology, but is also an M4 here at UNM. Dr. Larissa Maley, she's a clinical psychologist in the department, and she's also the director of clinical services at UPC and at ASAP. And then Briana Chavez is joining us, and she's the director of adult inpatient services at UPC. So it'll sort of be a tag team presentation. We're going to start off with Dr. Wylie and Dr. Ho, who are going to talk a little bit about sort of the need for this work group. So I'm going to advance the slide quickly. We wanted to start off, and this is something that Dr. Smart did in her presentation, and I just really liked it, and so I wanted to adopt it for all other presentations in the department. But the Indigenous Peoples Land and Territory Acknowledgement. So founded in 1889, the University of New Mexico sits on the traditional homelands of the Pueblo of Sandia. The original peoples of New Mexico, Pueblo, Navajo, and Apache, since time immemorial, have deep connections to the land and have made significant contributions to the broader community statewide. We honor the land itself and those who remain stewards of this land throughout the generations, and also acknowledge our committed relationship to Indigenous peoples. We gratefully recognize our history. Quick disclaimer, we're presenting on behalf of the department, but it's not like we're getting paid for this particular presentation. Our real interest is improving clinical care and reducing violence throughout the hospital. And I want to give a quick presentation outline. So we're going to break this into 4 sections. So as I said, Dr. Wylie and Dr. Ho are going to start, and they're going to talk about violence escalation and the need for change at UPC. And they'll talk about some trends and some future analysis they're planning on doing. Then I'll talk a little bit about theoretical underpinnings of violence risk prevention and mitigation. And that'll be a nice basis for some of the applied things that Dr. Maley will talk about and RN Chavez will talk about. So Dr. Maley will talk about primary prevention and action and some of the environmental and milieu changes that are going to happen at UPC. And then Nurse Chavez is going to talk about, in the context of secondary and tertiary prevention, how the DASA inpatient version, it's a risk assessment instrument, is being implemented at UPC currently. So with that, I'll turn it over to Dr. Wylie and Dr. Ho.
Hi, everyone. Thanks for attending today. So I first became interested in this in the winter of my my second year of residency when I was working on the inpatient wards in a PES. There was a sort of a temporary spike in violent outbursts on the wards and in PES. And at the same time, I was seeing a lot of our mental health technicians and nurses leaving. They were quitting, and pay and safety were 2 reasons that I heard brought up a lot. This concerned me for a couple of reasons. First, violence is a real, it really disrupts our therapeutic milieu. It's really hard to give good psychiatric care to people who don't feel safe. And so that's a significant barrier to care. And then the second reason was that I think especially in mental health, our nurses and the technicians that we work with, they aren't just keeping the rest of the team safe. They're not just delivering medications. They're also modeling responsible behaviors. They're de-escalating patients. They're really doing things that I think of as care, part of the care that we deliver. And so losing the expertise when these folks were leaving really concerned me. So I linked up with Dr. Quinn. We reached out to other people who became part of the working group, some of whom you'll hear from today. And then we started to discover all the other groups at the UPC that were already working on this issue. And so we've been trying to coordinate with them on a monthly or more frequent basis. So my role in this, I started by going to the literature. I started with PubMed, where I ask all my questions. And I discovered a couple of things pretty quickly. One is that there's not too much research that's been published. This is both a limitation and an opportunity. It means that there are few resources that we can draw on, but there's also room for us to contribute. A couple of trends that emerged from what I was finding is first, there was an emphasis on the use of standardized instruments like the DASA or the BROSIT to assess the risk of violence. And then all of these interventions that were successful were really multimodal. It wasn't just staff training. It wasn't just changing the physical environment to be more healing or promote safety, but it was also there was an aspect of cultural change, trying to get the whole institution involved and to address this on the altogether. So next slide. So this was one example of from the literature of a forensic system in Britain that had a success around changing their rate of assaults. These are forensic wards, so people with significant violence histories and serious mental illness. And you can see from the table there that over the course of their intervention, using this multimodal approach, they were able to reduce, most of their sites were able to reduce the number of incidents. The few outliers, they related it to specific individuals, although that's going to be an issue throughout any kind of intervention like this. The things I wanted to highlight here, they had a community participation that was really important. This involved not just staff, but also patients. And I think that we should keep in mind that patients are just an essential part of this community, and they are a really important part of reducing violence. They're also most affected by it in some ways. They had an iterative model. This comes to us from QI, where they'll take an intervention, apply it, measure the results, go back to the drawing board, make changes, apply it, so on and so forth. And then last was that aspect of cultural change that I mentioned, where they really tried to get everybody involved. Thanks. So I started applying this to our particular institution and looking at our PSI data. So every time there's an assault, a patient safety report should be filed. This is data from 2018, 2019, and you can see that the most common discharge diagnoses associated with violence were primary psychotic disorders, substance use disorders, and then major neurocognitive disorder. And this tracks with what's seen in the literature. So these diagnoses, along with male gender, history of violence, and then also involuntary hospitalization, are all associated with the risk of violence on an inpatient unit. I think it's important to note that this isn't just, these factors are also associated with violence in the community. And then also these patients aren't just at a higher risk of perpetrating violence, they're also more likely to be victimized. They're more likely to suffer violence. And so I think that's just important to keep in mind when we consider the characteristics of individuals who are violent when they're in the hospital. Next slide, please. So this is one future direction for us. So I was able to look at a subset of those reports, but of the 182 PSIs that were filed between 2018 and 2019, only 31% were identifiable. There were no MRNs for the others. And to me, what that says is as a system, we need to do a better job of making it easy to report and easy to report the important characteristics of each assault, and that will improving our information collection that way will help us to study the problem and study our interventions going forward. So with that, I'm going to turn it over to Dr. Ho.
Thank you, Dr. Wylie. So with this data set, as Dr. Wylie talked about, we kind of lost a lot of it due to the fact that the MRNs were not properly put in. So when we worked with it, we kind of cleaned up the data a bit more, and we had to remove the duplicates because it's not going to get you any more MRN information there. And then filtering out nonsense data at that point too, like social security numbers being put in, or just random, seemingly random numbers. So that left us with a little bit less than half of the ones where an MRN was filed. So this data has been collected since 2010, all the way up until this point through 2021. So we tried to filter out all these MRNs where a patient was associated with violence. So it's the red dot there in this. And we are going to separate the data out by year. And we're also going to combine it all to kind of aggregate it all together to kind of see what kind of trends we can see. So overall, losing all the PSI reports, losing the ones without MRNs, and losing all the duplicates, we're left with about 644 incidences there. So we'll compare those 644 MRNs, and we'll compare them to the total number, the total admits to our MHCs, and we'll kind of see what kind of what the data yields at that point. Next slide, please. We're expecting a few things to be overrepresented in this sample, this MRNs of interest, as Dr. Wylie already talked about: age, male gender, admission status, and as well as a bunch of the diagnoses. So we're going to just scan through all the ICD-10 codes, what all the patients received. Once again, there are things to be expected: schizophrenia, substance use, but I think we're leaving our hearts and minds open to being surprised. Maybe we'll see that there's something else going on regionally with our particular MHCs with patients who are violent. We've submitted this clinical data request, and and it's still pending, so we'll see what happens there. The graph here is just kind of a mock-up of how we'll see it, comparing the two populations, the control versus the MRNs of interest, and what we'll see there. Thank you much, and I'll pass it on.
Thank you, Dr. Wylie and Dr. Ho. I'm going to talk quickly now about theoretical underpinnings of violence, risk prevention, and mitigation. And really, this is just to provide a background and some theory behind the things that Dr. Maley and Nurse Chavez are going to talk about. So for anybody who's an epidemiologist or has an MPH, please correct me if I'm wrong, but I'm taking a public health perspective towards this, right? And I'm thinking about primary, secondary, and tertiary prevention. So when you're thinking about violence risk prevention, we can do the most at the primary level, right? Where we're focusing on all patients, and our job is preventing risk, right? We don't want risk factors to be popping up. Because of that, we're taking a more generalized approach, and we're really focusing on things that are universal. So how do we create a good environment? How do we create a good milieu? If we're taking a secondary approach, we're really thinking about a subset of people where risk factors are starting to pop up, right? And we want to focus on targeted intervention to address those risk factors. So secondary prevention is really, violence hasn't occurred yet, but we know there's a risk of it because these risk factors are there. And we want to make sure we address those risk factors and sort of diffuse the violence risk. Now, tertiary is where we sort of have the least flexibility in terms of what we do, but that's really focused on preventing the recurrence of violence, right? So it's a long-term response to somebody who's already been violent, and it's really an individualized risk plan. And this should be based on a violence risk conceptualization, right? What is driving this behavior? For some people, it might be psychopathology. For other people, it could be personality traits. For other people, it could be very situational. So you really have to have an in-depth understanding of who you're serving and how to conceptualize their violence risk. Now, when we're focusing on primary prevention, we're really asking ourselves two questions. How do we create an environment, an inviting treatment and living environment, right? So this isn't just the culture of a unit, this is also how the unit looks. And how do we foster a harmonious milieu where patients feel like they're, number one, respected, but they also feel like they're active participants in their recovery, right? So it's sort of a team approach. And so we're really looking at changes to the physical environment, motivational and recovery-oriented approaches, and then utilization of evidence-based psychosocial and medical interventions. One thing I was trying to do with these slides was use sort of more vibrant and relaxing colors, which Dr. Maley will talk about. But again, sort of prefacing some of the things we're trying to do in the hospital to create that more homey feel. Now, when we think about secondary and tertiary prevention, we're thinking about how do we address risk factors for violence as they come up, and then how do we address preventing the recurrence of violent behavior, right? So in one instance, it hasn't happened. In the other one, it has happened, and we don't want it to happen again. And we're really focusing on what I call the risk, I don't call it this, the literature calls it this, but the risk need responsivity framework, right? It's a risk assessment and risk mitigation framework. It's not just risk assessment. And the idea here is, as we identify these needs, we can address them, and that's going to make risk go down over time. So number one, risk isn't stable. Risk is also individualized. So the risk principle really means that the intensity of an intervention should match the level of risk that somebody actually presents. And so we accomplish this by assessing risk factors. The more risk factors that somebody has, the higher risk they're at. We want to give higher intensity intervention to people with a lot of risk factors and lower intensity intervention to people with lower risk factors. Now, there is a negative externality if you take a one-size-fits-all approach, because if you try to match, if you try to put people of different risk levels into the same intervention, there used to be a thought that people who are higher risk are going to come down in risk, and it's the opposite. We call it either deviancy training or delinquency training. If you don't match the risk levels together, people who are lower risk actually go up. And that's been shown really nicely with drug court research. Now, the need principle suggests that any intervention that we give needs to address an area of deficit that is dynamic or changeable, right? So what is amenable to intervention? And you can see that I have Maslow's hierarchy of needs here. When I think about this from an R&R framework, I'm thinking about criminogenic needs. So those are things like social support networks, employment history, mental health needs. But that's what we're thinking of, right? Is what are the things that are driving this behavior and what is changeable? So you can't change somebody's criminal history. You can't change somebody's past history of violence. So we don't want to focus intervention time there. We want to focus it on the things that we know can change in the immediate future. And this needs to be individualized. So if you think about a risk assessment instrument, so for example, the DASA has 7 risk factors, there's a ton of permutations of different risk combinations. And so it really has to be individualized. 2 people can have the same level of risk, but they're presenting that way for very different reasons. The last thing I want to talk about is what we call the responsivity principle. We are very good at addressing risk and needs at this point in risk assessment and risk mitigation, but where we fall down is the responsivity principle. And I was just giving a talk a month ago about this to federal probation, right? I think of responsivity as, well, how do we reach this patient? So there's sort of 2 levels to responsivity. One is general responsivity. So we want to use an intervention that we know is going to be evidence-based for whatever it is that we're intervening on. The bigger thing that we want to focus on is specific responsivity, right? How do we target interventions to only that individual's areas of need? But more importantly, how do we adapt an evidence-based intervention so that it's palatable for that specific person? And when you're thinking specific responsivity, you're thinking about a ton of different factors. So does somebody have cognitive deficits? Do they have reading and writing limitations? Is there a language barrier? How do you translate an intervention? Do they have physical handicaps, right? How do we need to address our environment so that it's accessible to somebody? Do they have mental health issues that you need to tackle first? Do they have interpersonal anxiety? Do they have a history of abuse and neglect and it's hard to build trust and rapport? Do they maybe not have a desire for change or treatment, right? And we're the home of MI here at University of New Mexico. So we know that just because somebody isn't motivated today, that doesn't mean they're not going to be motivated tomorrow. And we can meet them with an intervention that is going to move them along that continuum. And one thing I want to call more attention to is ethnic and cultural barriers. We're a very diverse state in New Mexico. I didn't really appreciate sort of the cultural diversity. Like, I lived in Philadelphia before this, very diverse city, but not like integrated the way that New Mexico is, right? There's pockets. And so when I came here, I really appreciated cultural diversity and how much people mix. So that is something that we really have to think about in New Mexico on all of our different milieus, because we have a bunch of different types of people who are all interacting. And you have to think about ethnic and cultural. I did consult with Dr. Smart about this. I apologize, I didn't change this. I don't think about them as barriers so much as bridges, right? How do we bridge this gap? So when I'm thinking about risk assessment and cultural competence, we want to utilize a risk assessment scheme that's valid for the individual, for the groups that an individual identifies with. And the idea here is that not all risk factors are equal for all different groups. So if you're using a risk assessment instrument that is normed on a Western population, but you're dealing with somebody from sort of a more Eastern orientation, you might not have the same, it might not predict risk in the same way. So you want to make sure that you're utilizing a risk assessment scheme that is valid for the group that the person identifies with. You also want to be aware of the potential relationship between cultures and risk factors when you're conceptualizing risk, right? So there might be a risk factor there, but you don't think about it the same way as you think about it from somebody from a different culture. So if we think about a collectivist culture, social networks might be much more important than some of these other things, right? So you need to think about that when conceptualizing risk and figuring out where to draw attention to first. The other thing that we want to consider, again, is culture as a responsivity factor. So how do you adapt an intervention to account for cultural differences? And how can you view culture as a bridge to cross? And so an example I like to give is, how do you navigate historical trauma or cultural mistrust, right? Are we going to interpret that as low motivation for treatment or low amenability for treatment? Because that's imbuing it to the person, right? As opposed to the situation. And if we know that somebody, or assume that somebody has this background, it's a lot easier for us to figure out, okay, I need to figure out a way to build rapport. It might not be that this person doesn't have motivation. It might be that I just don't have the in yet. So those are all things I like to consider when I'm thinking about risk mitigation and risk conceptualization. And one of the things that we're going to be stressing sort of as we move forward with the DASA. So that's the theoretical background for some of the things that Dr. Maley and Dr. Chavez are about to talk about. And you'll notice that we're only 20 minutes in, which means we have 40 minutes to devote towards the practical application stuff, because that's the most important stuff, how the hospital is going to be changing and how it's already changed.
Okay, thank you so much for that wonderful overview of the theory behind what we're going to be talking about next. So I'm going to be presenting on 3 different aspects of our proposed plan for the UPC adult inpatient program. We're going to be doing some restructuring, both from, as Dr. Wylie discussed, from a multimodal perspective. So we want to adjust the entire culture of how the inpatient units are running and how we're working with the patients in general, which is this therapeutic community model that I'm going to discuss. We also want to make some changes to the environment. So I'm going to go over some very specific recommendations for how we're going to make some environmental changes to increase regulation for our patient population, make it easier to provide these interventions. And then I'm going to cover very briefly some of the changes to how the psychosocial or psychotherapeutic program is going to operate within this model. So starting with that cultural shift is to cover, we're going to be adopting what's called a therapeutic community model, which has its foundation in inpatient psychiatric settings. It was originally developed back in the 50s in the UK and has been widely disseminated in major psychiatric institutions across the globe. It's also been utilized in correctional settings and residential substance use settings. So it's been applied across populations to show a way of really shaping populations in regards to managing risk and violence in those settings, empowering patients, and helping to create a learning environment where patients can not just engage in their own care from an active standpoint, but learn the types of skills that are going to benefit them in an outpatient setting. So a lot of the things that we're trying to target in terms of decreasing risk and events on the unit, and decreasing those readmissions. So successful outpatient placement is one of the big goals that we're trying to hit. The other thing that the TC model is really helpful with is because this is an underlying culture, it's not a specific intervention. It's not just a one technique that's going to be applied. slide. It's a culture that includes both staff and patients. And so it really is not just empowering for the patients involved in the model, but also the staff that are administering it. And so that's going to help us with our third major target, which is really decreasing our burnout risk for the very dedicated staff that work on our inpatient unit. So the TC model identifies how to organize and work with folks who are on an inpatient unit slightly differently than that traditional medically managed approach. So it includes really adopting an overall recovery-oriented, trauma-informed, and patient-involved program that allows for the creation of communities, which is where that term comes from, and requires active participation with both patients and staff, and gives them an opportunity to make decisions about their care while they're on the unit, and the types of the decisions that are going to impact their ability to sort of regulate and maintain themselves from an emotional place while in a setting where they have very limited controls, but doesn't take away the decision-making capacity of medical staff or psychiatric staff who are charged with their safety while they're there. Next slide, please. So this is just a very brief rundown to explain kind of how the model works, and then I'll dig into the specific components. So it starts with this idea of collective responsibility. So staff and patients are both members or owners of the community, which forms a sense of citizenship. So there's a level of care in all of the components that are talked about on the unit, where we all see something. We want to all do something about it. Like we care about everyone that's on that unit, their safety, their well-being. We care about what the environment looks like. If there's trash, we pick it up. So that sense of citizenship or fraternity, and that everybody is empowered with specific set aside spaces to actually discuss and talk about what might be a frustration or what might be an unmet need. So it creates an environment for patients and staff to advocate for each other, and a lot of social modeling can take place within those interactions, which then leads to a greater sense of personal responsibility for patients that can take that with them back into the community. So this model has shown to be very effective in avoiding unhelpful dependency on staff or techs, in terms of patients sort of feeling like they're in this disempowered passive place where they need to have things done to them or given to them. And it also allows for a greater level of self-care and self-regulation, because if I'm feeling really dysregulated, I'm feeling really upset by something, within this model, there's a space for me to actually discuss that in a pro-social manner, especially with support and coaching with therapeutic staff, to get that need met in an effective manner, rather than waiting until I explode and having that be regulated for me. So that's why this is highly linked to a decrease in off-task, violent, or elopement behaviors, and that decrease in readmission. So next slide, please. So elements of this model include, again, that shared responsibility with staff and patients and active participation. In terms of daily routines, with sleep, with snacks, with different activities on the unit, there's patient involvement in that decision making. There's also a heavy level of orientation and education provided to patients once they're stable enough to be inducted into the model. They're told, what this is, how this works, what's your responsibility, what's my responsibility, what are the limitations, and what are the consequences. So it's really clear from a behavioral standpoint where those parameters are. And this amazing thing happens even with very, very ill acute patients. When we give them clear communication about what those parameters are, they tend to follow them. It's in their best interest by and large, right? So there's a lot of education to develop that type of ongoing learning right from the get-go, and a commitment from all staff of every level to be part of that learning community. So every interaction with a patient becomes an opportunity to teach them something, to help them understand how that outburst impacted the other people in the community, or how that outburst made sense in the moment, but may not have actually helped them to get their need met. So let's talk through how they could get that need met in a more effective way. So rather than trying to control, we're trying to teach, so that that consistent modeling of good communication becomes the hallmark and the foundation of this model. The other thing is it really requires staff and patients to adhere to respectful adult person-centered communication, which again is going to translate to better outpatient stability, and reinforcing the behaviors that we want to see. And I'm going to talk in more detail about what are those the reinforcers and how do we shape behavior over time. Next slide. So the program can be broken down into these different components. One is that commitment and training for all staff. It can't just be the nurses are going to do this or the therapists are going to do this. It really has to be everybody that works on the unit participates in this program and understands what their role is and what are the expectations for their behavior and patient behavior. There's that orientation and education, which is done as soon as the patients are stable enough to be oriented. Every patient will have educational materials, either a handbook or a folder that guides them through that process and gives them a daily schedule. So this again allows for really clear sets of parameters. What is the expectation for your behavior while you're with us? How can you be successful and how can you get your needs met while you're here? It also includes the adoption of daily unit meetings. These are not treatment teams. Those are also a piece of this, but these are unit meetings that include everybody. That's the administration, the docs, the nurses, and the patients. Every morning we meet and we kind of have a huddle together and we say, these are the events that are coming up today. These are the things to expect. It's also an opportunity to highlight patients that are doing really well. So that way we can give a lot of positive reinforcement. And this is a place where if there is a patient that has a disagreement with a staff member, they have a need that isn't getting met, they want extra snack time, they would like to be able to use the comfort room when they'd like, and they don't understand why they're not being allowed to do that. Well, this is the daily meeting is when they can bring up that concern and it can be discussed with staff in a therapeutic manner to help them understand what are the limits, why is it this way, and what could be a potential compromise for them. Now, therapy staff will work with patients to coach and prepare them for asking or advocating for those needs to be met, but it does create an environment where that type of social learning can take place. It also allows for patient counsel, which is opportunity to step up in terms of responsibility. And so patients that are doing really well can be nominated by staff and nominated in that daily meeting for an additional task that day. And that task could earn additional rewards. So that's an opportunity for patients to, again, feel that sense of commitment and belonging to that shared space rather than feeling isolated or disempowered. And then because a lot of this comes with really clear behavioral planning, those behavior plans will then be translated to their guardians, parents, caregivers on the outpatient level so that the types of reinforcers that worked on the inpatient unit can continue to be put in place for additional stability outside. Next slide, please. So in terms of reinforcing behavior, obviously punishment works, but it's not the best. And so if we have the opportunity to only use rewards, that's the direction we want to go. So part of the TC model is going to include a contingency management program, which is where we use privileges and different items to reinforce the target behaviors. So some of those target behaviors are going to be things like going to following their group schedule, brushing their teeth in the morning, going to bed when it's bedtime. The different behaviors that we want to see for success and stability on the unit, we can reinforce with a daily point system. So again, that's why it's so important that everybody is part of this model, because all staff need to be there to witness when these behaviors are taking place to award those points. So we'll have point boards in all of the units where these points are viewable by everybody. It's very transparent, and our staff are trained on how to award the points, what are the target behaviors, and how patients can actually redeem their points for the types of things that that they want to earn. So this is another way that they can get their needs met, and they can make small choices while they're with us to increase that regulation. So this just becomes part of the system. And this isn't that far off from a lot of the pro-social behaviors that we want patients to be engaging in when they're not on our inpatient unit. So again, the TC model is a lot about shaping and providing the active learning about, okay, you would like that extra snack? Let's talk about what you can do today to earn the point to get that, right? So it's really about how they're getting their needs met rather than us just providing. Next slide. So this is showing you some examples, and I'm not going to go through all the details on here, but this is an example of how those appoints would be awarded. And I like the expression, they say that everything you need to know to be a successful adult you learned in kindergarten. So this is very similar to the things that we probably all were taught when we were in kindergarten, right? There was a star chart, there were certain rules for the classroom. And if we behaved in accordance to those, we got our star for the day. And as we accumulated those stars, we got to redeem them for certain things. So that's exactly how this will work. And this works with patients of all different ages, all different walks of life, because this is how we are socialized in Western civilization. So we're going to come up as a team with what are the specific items that patients are going to be redeeming. And it'll be things like, a unit allowed food and drink options, personal hygiene products that might smell different or more preferable, activity books, reading materials, games, different things that they can actually do to occupy their time, comfort items, stuffed animals, soft plush blankets, like stress balls, those types of things that will be available and that they can actually earn if they elicit the target behaviors, which again are the behaviors that we want to see them to elicit to be successful on the unit. And then they could also redeem this for certain privileges, such as having some control over their bedtime, over snack time, over access to music or TV, and making some of the choices that may not be available to them at the moment. Next slide. The next thing that we're going to be changing, in addition to that cultural shift with the TC model, are making some very specific environmental changes. So our goal here is to increase as much as we can with the environment, patients' ability to stay regulated and comfortable. So we are going to be changing the paint colors. We're going to be looking at different screens for the fluorescent lights to block out some of the fluorescent lighting. We're working with folks actively on figuring out a music program that will play throughout the day and maybe timed, like more activating music in the morning and more calming or quieting music in the evening, things that are without words and that are at the same rate as the human heartbeat have been shown to help regulate people. And then we're going to be getting some furniture options to help with some of that proprioceptive stimulation. So we'll have various options if people need to lay on the floor. We'll have some foam mats, bean bags, weighted blankets, different furniture that allows for movement or stretching. We're also going to be creating some comfort rooms on all the units so that patients that are really dysregulated, one of the things that we can coach them on in the TC model is when they're getting to that point, what are their warning signs and how can they ask to go to a comfort room? So that way they can go into a small space with a weighted blanket with lower lights and very low stimulation to help themselves calm down and get to a better space before it gets to the point where we have to do any kind of seclusion or restraint. And then we're also hoping to use essential oils or different aspects of aromatherapy, again, to sort of keep the system calm. And then if we're doing activity groups, to maybe have certain oils to help them be a little bit more alert and awake. Next slide. So in terms of the clinical program, which is the third branch of this, we're going to be doing some adjustments with how we work together. So now that we have a fully staffed therapy team and a case management team, we're going to be launching a much more involved intake assessment, which is going to go through motivational checklists so we can identify what motivates this particular patient, like what do they get excited about, so we know what would be a reinforcer. We're going to be be doing some of the risk assessment pieces that were already mentioned earlier, in addition to a whole host of psychosocial assessments. So we really have a better idea of who is this person and what are their unique needs going to be. Then we're going to use a functional assessment, and for our GERI patients, a dementia assessment as well on a daily basis, which helps us to assign a specific track and grouping of programming. So not having a one size fits all for the therapy that's going to be provided to them. And so they can change tracks or move up and down that track depending on that daily assessment. So as patients get better, they can have increased activity and maybe even more complex activity. And as patients might experience an exacerbation in symptoms, or they come in at a very high acuity, they're going to have increased rest and rec time, and not as much of the therapeutic programming until they're at a space where they can participate. So this is showing you some of that workflow. Next slide. So we're going to have two tracks and a separate pullout for our patients that have a primary dementia process. But for on our adult units, they're going to be divided into either the COPE track or the CALM track, and then divided further into their level of functioning. So COPE lines up with our outpatient COPE clinic. And so these are our patients with primary psychotic condition, SMI, TBI, severe developmental disability, where there's some sort of cognitive piece that's really a part of their presentation. And you can see how we've broken it down by group, individual, family, and then SUD offerings or substance use disorder offerings. Now, if they're in the engaged or moderate functioning level, they'll have one set of groups or individual services offered to them that's really geared to help them acquire skills and stabilize even further while on the unit. Once they're at a much more stable place and they're preparing for discharge, then we would move them to a different schedule where it's really focused on what is that discharge plan, how are they going to manage their medications, what are the things that are going to need to be set up for them so that there's successful transition into their outpatient level of care. So this will allow patients to move up and down in terms of acuity, but within a track that's really much more targeted for their unique needs. And then the next slide, if you don't mind transitioning, is just to give you an example of the CALM track, which lines up with our newly developed CALM clinic on the outpatient side here at UPC. And this is sort of really to catch our patients with primary mood disorders, personality conditions, PTSD, trauma-related conditions, disorders, primary. But those that are belonging to that sort of do not have a primary psychotic condition. And so you can see here the group offerings and the individual and family offerings are really focused on symptom remission for those different conditions, where we're looking at a lot of increasing their distress tolerance and emotional regulation and dealing with issues like SIHI prevention, interpersonal effectiveness, social network building, these types of really brief types of skills acquisition at that moderate functioning level. And then again, when they move to the higher functioning or more stable functioning category, then they would be focused on, okay, how does this translate to my outpatient care? What is it that I'm going to need when I'm discharged tomorrow, when I'm discharged in the next few days, to make sure that I'm really successful? Let's break that down into some really clear, concrete goals and put that in a schedule for you, so that when you leave, it's more than just your next appointment. It's more than just your meds list. It's a whole handbook of how do I take care of myself. So I think that's all we have covered for this section, and I can pass it on to Ms. Chavez.
Hi, everyone. I'm Briana. I'm the director for the adult and geriatric units here at UPC. And just to orient, for those of you who have never been to our units, we have 2 adult units, east and west, and 16 patients on each unit. So the DASA, which is what I'll be talking about primarily, is going to be rolled out on our adult units. We are currently piloting it on our east unit. If I could get the next slide, please. So just a little bit of background on the DASA. Ooh, the one before that. No, back. Yes. So just a little bit of background. We looked at several risk assessment tools for aggression to use on our inpatient unit, including the nursing leadership. And we landed on the DASA because it seemed like it fit within our patient population the best, and also It's pretty easy to use and it's quick, which is a good selling point for the nurses to actually get buy-in. So once we decided that we wanted to use this tool, our executive director, Mary Perez, was able to reach out to the author, and we were able to get permission to use the tool here at UNM. So what it is an assessment that the nurses do every 24 hours. So currently on the East unit, the nurses are doing it at the end of day shift. It considers seven risk factors, which I'll go over in the next slide. And they're scored as either present or not present. The higher the scores, the higher the risk. And you'll see at the bottom, low risk requires no action, moderate risk requires increased monitoring, and high risk requires a risk management plan. And while the tool identifies that this is necessary, it doesn't give us the intervention. So I'll talk about that a little bit later. Next slide, please. So the risk factors include irritability. So is the patient easily angered or annoyed? Impulsivity. Does the patient have dramatic fluctuations in mood? The inability to remain composed? Unwillingness to follow directions, sensitivity to perceived provocation. So do they misinterpret other people's behavior and respond disproportionately? Are they easily angered when requests are denied? Do they have a negative attitude? And the last one is verbal threats. So, and do they have an intent to intimidate or threaten another person? So as you can see, all of these risk factors can be scored by just observing the patient throughout the day. We don't have to ask them any specific questions. Next slide, please. So what it looks like physically is right now it's on a sheet of paper, and every patient on the unit has a sheet of paper that has their scores for a week. So we just go through every night and determine their score, and we can see if they've increased or decreased in their score throughout the week. It fits well into the workflow. The nurses are saying that it takes less than 5 minutes at the end of the shift, which is really good. And they do feel like it does highlight aggressive behavior. So I've gotten several stories back, but one that really sticks out to me is that we had a patient that we knew had a high DASA score, so we were monitoring him more closely. The doctor had to give him some news about his discharge plan, and so we knew that there was a possibility that he could become aggressive, and he did try to attack one of the physicians, but we had a tech there and we were ready for that, so we were able to prevent that assault. The next thing is that most of our patients actually score 0 or low risk, which means that the tool is meaningful, right? I was concerned that all of our patients would score like in the moderate range and it wouldn't really be meaningful to staff, but we really are able to identify 1 or 2 patients at a time that are at increased risk for aggression. And then I included this graph. It shows our assaults for the rolling calendar year. So the green line is the patient on patient assaults, and the orange is patient on staff assaults. So we implemented the use of the DASA in May. So obviously there's not enough data to see how effective it is, but it does give you a good idea of how much work we have to do and how much work we've done. So hopefully we'll decrease assaults to 0. Next slide, please. So the next steps for the DASA is to roll it out to the West unit. And then the big thing is to include the score in our treatment team. So for those of you who have not rounded on inpatient, our treatment team consists of the physicians, residents, nurse, and the therapy team. And so we really want to make this meaningful so that when we bring the DASA score to the treatment team, the other disciplines know what we're talking about. Dr. Fairfax-Columbo has worked with a student, I believe, to create interventions that are useful based off of the risk that the patient poses. So if the patient is making verbal threats, he has a specific list of interventions that we can use to help address that concern. So we really want to bring that to treatment team and discuss as a team so that we have a clear plan for every patient that's at high aggression risk. And then finally, we want to put the form in the electronic medical record.
Thank you, Ms. Chavez, and also thank you for acknowledging the undergraduate student who helped me. Want to give a quick shout out to Margaret Albach. If she's, I did send the grand rounds to her. I can't see everybody because I'm sharing the slides, but if she's here, a quick shout out to you. Thank you for that help. So some quick takeaways. Mitigating risk for violence really starts with preventing risk factors from occurring in the first place, right? And so that we really need to focus on creating what is a warm environment and a harmonious milieu where patients feel respected and they feel like they're partners in their recovery. And that's a key facet of primary prevention. Now, when we're thinking about mitigation, it's continuing as we address specific risk factors as they arise. So we're using, that's what we're using the DASA for. And so as a risk factor comes up, like Nurse Chavez said, Margaret had identified some different interventions that might be helpful for addressing irritability and impulsivity, right? So what can we do in the moment so that we can have a tailored risk plan for this person? The other thing I'm really hoping that this highlights is how dedicated UPC is to embodying the principles that we talked about earlier. And that's really demonstrated through the fact that the DASA is already being implemented, and we're making a lot of steps towards implementing these other things throughout the hospital. So a little bit of a different grand rounds presentation. I really wanted us to focus on what is happening at the hospital and what's happening on the ground. And with that, we'll take any questions or comments that anybody has. If it's tailored for somebody specific, please just make sure to address the comment to that person. Let me look in that. I can see that there's some in the, any questions in the chat? It looks like in the chat, questions were sort of already addressed. So does anybody have questions that are not reflected in the chat?
Jaymes, this is Kathy Holland. I have a question for Dr. Maley. And the question is that what you've outlined sounds fabulous in so many ways, and also very labor intensive. I'm assuming you've added staff in order to make this work. And then secondly, what's the typical duration of inpatient treatment? Because this sounds so complicated and really hard to make work if people are just in for a few days.
Hi, yeah, that's an excellent question. I appreciate that, Kathy. I can't answer. I'll ask my colleague, Ms. Chavez, to answer the typical duration. My understanding is about 3 to 7 days.
Yeah, I think it's 3 to 5 days, a little bit longer on Jerry.
Okay.
Yeah. And what we're hoping, let me answer your first question. Have we added more staff? We have not added more staff as much as we have reorganized staff. So over this past year, we have completely restructured the clinical side of the house. So our prior utilization of master's level counselors and social workers has been primarily for discharge planning. They have not been involved in the therapeutic offerings. And we were using CSWs to run what were essentially rep groups. We've now reorganized that structure so that we have CSWs and dedicated case managers doing the discharge planning from day one. And then we have an entire team of therapists, actually 2 per unit, 1 per team, to have hands-on individual attention to the patients that they are assigned to for that course of care. Our plan is to have these, even though it looks complicated, these different offerings, they will be templated schedules. So the daily assessment that the patient gets, there'll be a decision tree that directly relates to, based on this, they will get this schedule. And that will be discussed in treatment team every day. So it's going to be automated in the sense that patients, as soon as they are alert enough to be active, which usually happens within that 1 to 3 day time span, then we can get them actively participating in what's already running. We have a number of offerings occurring at the moment. So it's just going to be making that even more robust and a little more specific, and then adding on those additional assessments so that we're really clear in terms of when we have a patient that needs a specific behavior plan or the set of reinforcers that may vary, that they can access that. And then the contingency management piece is going to be run by both Briana and my teams. So we're over this next 6 months or so, we're going to be building out all of these pieces and training both of those teams to be able to administer that in the moment without need for team discussion.
Wow, thank you. That sounds great.
Thanks. I hope that answered your question.
Yes, it does. It does. Thank you.
If I can make a comment, and of course, congratulations to the team. This is an example of multidisciplinary work. This is what we are about. And what Dr. Maley mentioned is not more numbers. It's not that we hired more, it's with the same people. So really my congratulations to all of you and for taking so good care of our patients. Thank you so much.
Any other questions?
Hi, this is Lisa Herrera. I'm one of the PGY3s, and I'm so sorry if I missed the answer to this question previously. My question is, as our patients are working with these amazing groups on the inpatient side, I'm so excited for the work you guys are doing. How, as we as the outpatient providers, can be connected to that as well?
Could you give me a little more information about your question, just so I understand? What do you mean by connected to those groups?
Absolutely, absolutely. So we want to, it's the outpatient providers for a lot of our patients who continue to see us at MHC. I was just curious if there's some way that we either can be informed of the kind of behavior plan going forward from part of like the discharge summary, or whether it's like a power chart message, some way that we can kind of support our patients with these as we see them on the outpatient side. I hope that makes sense, and I'm not quite sure who the question will be directed to.
I think I understand. So you're saying, how can you get communication about what they were doing on the inpatient so that you can continue it on the outpatient?
Yes, ma'am.
Okay, perfect. So we are part of our workflow is going to be including inpatient treatment planning for all of these folks that will also have daily notes put in it. And so that will be the golden thread of everything that happened with that patient from a clinical vantage point. And it will also include those daily assessments and which track they were on and what were the components of the program that they participated in. And so we're hoping that since it's essentially the same document, that we'll be able to translate that to the outpatient treatment plan as part of their discharge. So all you would need to do in your workflow would be to go there and read that summary. So that's our hope, to be able to bridge that gap. But if you have other recommendations of how to communicate more effectively, at least within our system, I would love to hear it. So please feel free to send those ideas my way.
Yeah, absolutely. And I'm just kind of curious because I'm new to the power chart documentation as well. We fill out this treatment plan through power chart. Is that where this new information will be, or is that somewhere separate?
No, that is the document. What I'm hoping and what Briana and I are going to be working on is maybe tailoring that document and having an extra tab added for some of this information, because you can see it's already highly templated out and there isn't a ton of space for us to put these new program components. So we'll probably need to add an extra tab. And now that you're bringing this up, I think it would be useful for us to also create some kind of communication for all of UPC to let people know once that's there.
Thank you so much.
So I can see that we're just about out of time. I wanted to give Ms. Chavez a chance to plug some of the other working groups that we have. So this is one working group that people can get involved with if they want to, but we have a bunch of other ones. So Ms. Chavez, can you sort of just run down those groups quickly?
Yeah, so we have the Collaborative for Safety and Recovery that meets on the 4th Tuesday of every month at 2:30. And that's where we invite techs, nurses, security, quality, doctors, residents, whoever, everyone can come, and that we discuss any type of safety concern at all. So it could be falls, assaults, whatever's going on that month. We also have RCAs that happen every time that there's an assault, we're trying to coordinate an RCA. So that would include the attending who's covering the team, or the attending in PES, the resident if possible, and then the therapy team, nurses and techs. Mary and Dr. Quinn sometimes come, or actually usually come to those. We have the physical environment work group, which is kind of on pause right now, but it does meet from time to time to discuss environmental improvement projects. The music therapy and stuff like that have come out of that group. And I think that that's it. And then we have shared governance for our staff and monthly meetings. Yes.
So if you're interested in any of those, please reach out to Ms. Chavez. We'd love to have more people contributing their thoughts. Thank you, everybody, for letting us present this as a group. Very much thank you to CBH for really letting us showcase some things that are going on in the hospital. And again, just that focus on the continuity of we're bringing people in from the community, and the goal is to get them back out into the community, living the lives that they want to lead. And so hopefully this presentation gave a good sense of how we're working to improve in that area and really be on the cutting edge of what inpatient units are doing, particularly in academic medical centers. So thank you, everybody, for presenting today, and just email us if there's any questions that we can answer that we didn't today.
Thank you all.